Thank you. My name is Greg Swiedom. I'm a clinical supervisor here at MD Anderson Cancer Center. I have over 20 years of experience. Today I'm going to cover how at MD Anderson we develop and introduce a new workflow or treatment technique. I'm currently in the process of developing a SOP for a maskless workflow for us. So for those of you unfamiliar with us, I'm just going to go over a few things about our institution. MD Anderson is one of the world's most respected cancer centers focused on cancer patient care, research, education, and presentation. The institution is part of the University of Texas medical system, is one of only 53 comprehensive cancer centers designated by the National Cancer Institute. A couple FY22 quick facts about us. We have over 20,000 employees, including 1,800 faculty members. Currently have over 175,000 patients registered with us. Last year, we saw over 1.5 million outpatient visits. We currently have 757 hospital beds at the main center. We performed over 20,000 surgeries and over 500,000 imaging procedures. As you can see, we're quite a large institution. We're larger than some small towns. I've been with the institution for 20 years, and there's still some part of the hospital that I've never seen before. So that's how large we are. So what does our radiation oncology department look like? We have 95 radiation oncologists, 74 physicists, 172 RTTs, including supervisors, 80 dosimetrists, and 60 nurses. We're one of the largest rad-onc departments in the world. And I wanted to give you just a general idea of how the scale of our department, because it's going to be relevant to the considerations and challenges when we're developing a new workflow, like the maskless workflow. Our oncologist, physicist, and dosimetry team specialize by service line. So what does that look like? We have several service sites throughout our Houston area locations. We have at the TMC, at the main center at the TMC, we have the main center building and the ambulatory care building. Those buildings are separated by service line. At the main center, we have thoracic, lymphoma, CNS, GI, and MELSARC. And that is where our inpatient towers are connected. Over at the ACB, we treat the breast patients GYN and GU. When we started to separate many years ago buildings and services, at the main center, we chose the services that patients typically go inpatient more often. That being said, when patients from the House, Houston area locations, and ACB do go inpatient, we do have to treat them at the main center. And that's one of the main reasons why we have recently got a SGRT system over at the main centers to really keep the same level of patient care from the ACB transferring over to the main center. So being such a big, large division has its advantages and disadvantages. One of the advantages is we have access to many resources. Oftentimes we could pick multiple vendors for certain technologies and really evaluate which really suits us best. One of the disadvantages is we're just not as nimble as smaller institutions, and we really have to plan many years ahead and really understand where we want to go, and we want to push where we're aiming and where we really want to go. So we have to really meticulously understand where the technology is moving to and make decisions based on that. We can't really make quick turns and quick decisions like a smaller center would. I always like to use a cruise ship analogy when we're talking about us as an institution. We really just have to slowly move the ship towards where we want to go. We can't really make a sharp left turn in any way. So a little about our history with SGRT. Our first system was installed over 10 years ago. We have 4 Align RT systems at the ACB Center, mainly treating breast cancer treatments. We have recently installed one Align RT system at the main center last year, like I said, to really help for patients to go inpatients that we could treat over there. We have over 11 CRAD systems at the house. Randy told me not to bring up the opposition's name in my presentation. So, and we have possibly two more future CRAD systems going into our PTC facility. So now that you have a little bit of background about our institution, I want to give you a little insight on why we decided to go and develop a maskless workflow. Since we recently installed the Vision RT system at the main center, I thought to myself, like, what patients and treatments could really improve and really help our since we have the capability, what patient treatments could really benefit from the SGRT. After I came across the presentation from Centura Health, I thought that their maskless workflow would really benefit our head and neck patient treatments on our lymphoma service and head and neck service. Specifically, our patients that struggle with claustrophobia and extreme cases, patients that need anesthesia. Roughly a third of our patient population is treated with some form of anxiety medication when they're treated with a mask. Also, we treat from around 2 to 5 patients under anesthesia that need anesthesia to get through the mask treatments. I don't know if any of you guys have ever treated a patient with anesthesia under the mask, but it is definitely suboptimal. Oftentimes, when we have to do that, we have airway issues, oxygen saturation issues, and if you can imagine putting a patient under for a full head and neck treatment, about 30 fractions is quite dangerous, because every time you put a patient under, there's always a risk there's just always issues when you put a patient under anesthesia. As you can imagine, if you have to put a patient under for 30 fractions with anesthesia, it just ties up a lot of resources. So, anesthesiologists, CRNA, they have to recover, and after anesthesia. So, I'm not sure how much anesthesia costs, but I'm guessing that putting a patient under for 30 fractions is not cheap. So what does our new process workflow look like at Anderson? First, we got to get MD buy-in. That could either come from top down, from physicians asking us to help develop a workflow, or from bottom up. In this case, from our therapy team really reaching out to our doctors and our head and neck team to really gauge interest if a maskless workflow was something they were interested in. After we got buy-in from our head and neck team, we just started the process of gathering information. Our Vision RT partners and trainers were very helpful, and we set up a few Zoom meetings and just got as much information about the workflows we could, took a lot of notes, and we're able to set up a time for them to come back and actually have on-site training with us and really work with us from the sim all the way to treatment on a therapy volunteer patient. So after they came on site, really gave us an opportunity to have the MDs there and a couple of our physics team there to really understand what is needed to implement a workflow like this. And as you can imagine, anytime you implement a new technology like this, and especially a workflow like a maskless workflow, any kind of on-site, hands-on presentation really helps out. After they came on site, we got all the notes, we got everything ready. The next step is to actually create a SOP. So to the right there is typically what one of our SOPs look like for us at MD Anderson. When we write these SOPs, there's a lot of factors we have to consider. For us, since we have two different vendors for SGRT, when writing this SOP, it has to make sense for both CRAD and Vision RT. So that could be quite challenging. There's a lot of collaboration between me and the other supervisors from the house, and I'm still working on this. I'm on the second or third revision. So hopefully, by the time a few weeks from now, I'll be back in Houston, and I'll be able to move on to the next step. So the next step, after we get a pretty solid SOP written, it goes to our new process review committee, and this committee is comprised of a few physicists and a few MDs. And what we do, the purpose of this committee is for them to read over the SOP that's created and to make sure that it makes sense for somebody reading it that is not really familiar with the workflow, and they could give feedback and really optimize the SOP. Usually when it goes to NPR, it gets sent back, and we have to do 2 or 3 revisions before it gets through NPR committee and really makes sense for everybody. And once the revisions are done, then it goes to our big ClinOps committee. The ClinOps committee is where all the MDs and all the physicists really dive into the SOP, make sure it makes sense for everybody. They get to pick it apart. So typically, once it gets to the ClinOps committee, the SOP is on its final revision, and they debate whether it's something that we should really implement in a clinic. So what are our goals and metrics when developing this maskless workflow? So after speaking with the head and neck service and APPs, they thought that a reduction of anxiety medication by 30% was a goal that we could achieve, if not more. There's going to be some patient population that is still going to need some sort of anxiety medication just to get through it regardless, but a reduction of 30% they thought was achievable. Also, a big one for me is eliminating the need for anesthesia for the patients. As I explained before, it's just such a strain on resources, and if we could get the need for anesthesia down to 0, that would be great for the clinic. Eventually, we want to move to a maskless workflow for all our head and neck patients. So I think we can get there. We have a large head and neck oncology department, so getting everybody on board is going to be a challenge, but I think we're going to eventually get there. So our challenges. One of our main challenges for us is logistics. Since we only have one SGRCG system currently at the main center, training becomes an issue for us. There's over 100, like I said, we have over 170 therapists, and our therapists typically will rotate over the weekend and help with treatments over the weekend. So what does that look like for us when we only have one SGRT system at the main, and our house team members are familiar with CRAD? So one of our strategies that we use is every special procedure, we have training modules that we produce that could either look like that could either come by via a PowerPoint or videos. We're really working towards a model where we really like trying to transition to all our training modules to be videos. We have an in-house institutional videography team that we're going to start to implement to make really nice videos for all our training modules. Like I said, our current resources, we only have one SGRT system at the main center. So if a patient comes to us and our therapist is not familiar with workflows or SGRT system, we have to figure out how to cover that. Is it possible to pull another therapist off another machine to help cover? We're really working towards a model where our lead therapists are really our champions for certain specialized treatments. But currently, with our staffing issues, it's just a slow process. So hopefully, eventually, when we're fully staffed, we're going to be able to use our lead therapist to really help cover these treatments that are unfamiliar with our therapist. So like I said, one of the other challenges is just our homogeneity. As our house centers grew organically, certain vendors and certain equipment were chosen for the needs of the clinic at the time. A few years ago, our leadership has started what we call a 1RO initiative to really bring us back closer, to really think about and make decisions that make sense for all of us as a whole, and that being SGRT included. Hopefully, at some point, we'll get to where we only have one SGRT system. Hopefully, it's Vision RT. Also, one of the challenges is everybody is just change enablement. So anytime you have a new workflow or a new technology that comes in the clinic, there's always going to be some resistance and some skepticism that you have to get over. We have a wide range of MDs with different levels of experience and levels of interest. So getting everybody on the same page and getting everybody to see the benefits of new technologies and new workflows is quite a challenge. I think once we start small with our small head and neck patient population that needs anesthesia and medication, I think once the doctors get very comfortable with those treatments, I think we could really expand it to the whole head and neck population. So what are our future plans? Future plans is to really develop a more robust training program to really help with our logistics problems. One thing we're looking into is having our partners at Vision RT really come in for training at a more regular cadence. Even though we really rely on peer-to-peer training from our therapist to therapist, my experience, I feel like every time that happens, there's always something that gets lost in translation. So yeah, our Vision RT partners have been very helpful in we're working on getting them to come in at either bi-yearly or yearly. So also we want to pinpoint other treatment techniques that's going to really benefit from SGRT. Something I'm really looking forward to is creating a workflow or a pathway for our craniospinal treatments. I think that's really going to help with setup and speed the treatment process. Because as you guys know, craniospinal treatments could often take a long time. There's a lot of imaging involved. And I think one of our treatments, one of the treatments that SGRT will benefit the most is really our craniospinal treatments. So Also, we just need, also in the future plans is to investigate expansion for our SBRT cases, SGRT cases, I'm sorry. We are also looking into treating our SBRT and SSRS cases with SGRT. So I'm glad I'm here today, seeing all these presentations about SBRT really gets me excited. So investigate expansion. Hopefully there's more SGRT systems being installed at the main center. So yeah. Thank you for your time.